Hi, my name is Ryan Wolski. I'm a second-year internal medicine resident at Advocate Christ Medical Center, and I am here today to present a case that we had on the floors at Christ of Bouveret syndrome. So Bouveret syndrome is an incredibly rare condition. It's a complication of cholecystitis that makes up less than 1% of all cholecystitis cases. What occurs is the gallstone gets so large that it causes pressure necrosis on the wall of the gallbladder, which can eventually erode through the wall of the gallbladder and even into the duodenum and cause a duodenal obstruction. For our case, we had a 68-year-old female who had a known past medical history of gallstones and hypertension. Her main complaint was that she was having several days of severe abdominal pain and nausea exacerbated by eating, which are very typical signs and symptoms of cholecystitis. On her physical exam, she did have a negative Murphy sign, but she did have mild tenderness to palpation in the epigastric region. Labs showed normal LFTs, normal total bilirubin, as well as normal alk-phos. But in the ED, they did get a CT abdomen and pelvis because of these non-revealing labs, as well as her severe abdominal pain, which you can see on the right side. It showed a 3.8 centimeter gallstone perforating into the duodenum, and it was even concerned that it was causing an obstruction. So on our image, the red arrow, you can see an air behind the gallstone in the gallbladder. The green arrow shows old gallstones that are also still quite large. And then the yellow arrow shows the culprit gallstone being 3.8 centimeters all the way in the intestine. Then ultrasound of the right upper quadrant was also obtained, which showed many of the same findings, with a cholecystoduodenal fistula and even an obstruction of the duodenum. So for treatment, we consulted surgery, who took the patient to the OR for a major reconstruction. Initially, they attempted a laparoscopic approach, but due to the size of the gallstone, it had to be converted to an open operation. The patient had prolonged NPO status, so for that reason, she even required TPN during the course of her treatment. And then she was finally able to eat on postoperative day 4 and discharged on day 5. So she had a major reconstruction because the fact that there was now a fistula between her duodenum and her gallbladder, which meant that she needed a gastroduodenal reconstruction. So in this case, as I noted earlier, it's a very, very rare condition. Gallstone ileus, which is where the gallstone causes a abdominal obstruction, only comprises of 0.3 to 0.5% of cholecystitis cases, and then Bouveret syndrome is only 1 to 3% of all gallstone ileus cases. Risk factors for Bouveret syndrome are similar to those that cause gallstones, such as being female, being older, and having other medical comorbidities such as obesity. Suspicion should be high for Bouveret syndrome in patients with symptoms of gastric outlet obstruction, as well as cholestatic lab patterns. Our patient actually did not have cholestatic lab patterns because I'm suspecting it's because the gallstone was actually not in the biliary tree. It had eroded through the gallbladder all the way into the intestine, leaving the biliary tree largely intact. And there's really no standardized treatment for this condition because each treatment really has to be tailored to the individual patient, such as in ours, where it was initially a laparoscopic procedure but converted to an open surgery because of the size of the stone. So this is a very rare condition, but it is associated with significant mortality if it's left untreated. And then identifying Bouveret syndrome as early as possible and coming up with a customized treatment plan for each patient is going to enhance outcomes overall.